Well, good morning, good afternoon, good evening, depending on where you're with us. And Dr. Nicholas Amani Hamman, the head of the Snakebite Treatment and Research Hospital, Kaltungo, one of the largest in terms of patient load in sub-Saharan Africa. I'm excited to present this very important perspective from findings from our study on epidemiology of pediatric snake bites in northeastern Nigeria, which has been published just last month by BMC Pediatrics, and we hope to look at it, this topic, pay or perish, snake bites, unfair choice. Can we proceed? Yes, WHO has already presented there are 55.4 million snake bites occurring each year, out of which we have 2.7 million envenomings with approximately 138 deaths. In Nigeria, we have about 43,000 cases occurring per year with 1,900 deaths also within that same period of time. And children account for a little above 30% of such cases. And what is so interesting about children is the fact that they have high vulnerability due to their smaller body size, their high venom per kg, and quicker progression in terms of poor outcomes. And also, they also have lower physiological reserve. Important to know that they are also snake bite in a child means loss of schooling, loss of productivity, and also possibility of a lifelong disability. Let's move. All right, this study was published last month by BMC. It's actually a retrospective hospital record review, which occurs at the Snakebite Treatment and Research Hospital, Katungo, in northeastern Nigeria, which is actually a regional referral center, one of a hospital of its kind in the world. And this period the retrospective review was conducted between January and December 2024, where we saw about 723 children out of 2,192 cases that were seen in the facility. These 723 were aged 0 to 17 years. And the aim of this research is actually to describe the epidemiology and management and outcomes of cases in such age group. Next slide. Now, there were 480 boys out of the 723 and 243 girls. That's the male gender forms 66%, and the median age group was 12 years, and it's most frequent between the ages of 10 to 14 years, where we had 41%. And of course, interestingly, we have under 5s too, which forms 7%, about 49 cases. And the peak period of time was April, where we had 14% of bites. And of course, from the study is more also around the rainy season, which is actually consistent with previous studies. And 60% of those bites occur in the upper limbs. This is unlike the global trend where we have snake bites occurring in the lower limbs. This is actually due to the foraging activity of children and their inquisitive nature. And naturally, whenever a child sees something new, the first point of contact is usually his hand. And 77% of those cases were bitten by scarped viper. And of course, the rest percentages were shared by different species like cobra, bitings, ariatins, and of course, other unknown species as patients that were not able to identify the species that bites them. Next, please. Next, please. Now, what we notice that about 65% of those patients arrive hospital 24 hours post-bite. Interestingly, those ones were linked to worse recovery. And also, we also noticed that there are also an element of in-hospital delay where among those given antivenom, 68% of them got it greater than or equal to 1 hour after arrival. That means this dual delay is a hidden killer. It may be due to transportation, maybe traditional care, which is usually the first point of care whenever patients are bitten by snakebite. Can be also due to cost or payment, which is actually the most common, and also can be triage bottlenecks that usually occur in the course of referral. Next slide. Now, 78% of our patients receive antivenom. And around out of the 78%, the 567 patients that received the antivenom, 71% of them had single vial, and which is consistent with a randomized controlled trial that was conducted in our facility just a year ago, which found there is no difference between a vial and a single vial of AKITAP ICP. And of course, when we did a analysis, we noticed that children who paid for antivenoms had more poor outcomes than those who treated for free. Now, the scenario here is that within the first 6 months of the supply of that year, we had a free antivenom that was supplied by the Nurses Development Commission. And of course, all patients that came in were able to receive one antivenom within 1 hour of admission. And from the last part of July to the almost November, there was scarcity of antivenom. And of course, those patients had to go to the pharmacy outlets within the town to buy those antivenoms. So at the end of the day, when we did analysis, we discovered that those who paid for such antivenom had more worse outcomes than those who treated for free. Next slide. Now, 87% of our patients required without complications, while 13% of them had various levels of adverse outcomes, with 52 having to go to the debridement, 18 had amputations, and 21 patients died. This is just, for us, is just a picture of statistics: 52, 18, 21. But behind every statistic, there is loss of childhood, there is family trauma, there's economic burden in all of this. Next slide. Now, children arriving late. From all my previous presentation, you notice that those who arrive late and pay for antivenom were least likely to survive intact. They will have to go through death, amputation, or debridement. This is very interesting, and in contrast, patients that have HIV, malaria, and TB have either free or subsidized treatment at the point of care. However, patients with Snakebite will have to pay upfront cash at commercial pharmacy outlets to be able to receive treatment, or they will have to wait till when their families were able to get these things. This is not just a medical problem, it's also a justice problem, where the same elements affecting a particular age group with different outcomes. Next slide, please. Now, if you look at it from the global funding disparity, you discover that HIV, TB, and malaria had a little bit of favor when it comes to global funding. The Global Fund provides 59% of all international financing for malaria programs. And as of June 2025, the Global Fund has invested over $2.3 billion in malaria control programs. And the donor R&D investment, which is actually for the entities, shows that HIV, tuberculosis accounted for 65% of the money that has been spent, while Snakebite lies down in the pecking order. But now, if you look at Snakebite envenom, you notice that in 2017, the WHO declared Snakebite as neglected tropical disease, highlighting its significant public health impact. But when it comes to finding, the WHO strategy aimed at to have this date by 2030, and has an estimated cost of about $137 million. However, as of 2024, not all of this funding has been secured for such particular elements. Now, coming back to our communities, a vial costs around 120,000 to around 40,000, which is around $80 to $93 in pharmacy outlets. This price is beyond the reach of many rural families, and those families will have to be forced to either lease or sell their farmlands, sell their livestock, borrow, or maybe in sort of like community gathering in such a way they will gather money for such particular treatments. So such particular things, this process takes a long time for those things to be gathered before these drugs are purchased. And this processes actually translates into delay. And interestingly, is this same delay that is associated with poor outcomes. And so survivors end up with amputation, contractures, trauma, loss of schooling, And in the health system, you have a lot of stock out. You have longer hospital stays because of debridement and obstetricia. You have costly surgeries because of these things, and all boils down to the economic status of the patient presenting. Let's move. Now, this matters to us because the snake bite disproportionately affects children who are the future workforce, and farmers and herders who are the food security backbone of every country. So if we are neglecting them, we are actually increasing intergenerational poverty, and we are weakening the rural economy, which forms the basis for every other economy that is being built. So therefore, a preventable justice is sustained by lack of donor priority, whereby some particular elements are valued more than other elements. Let's proceed. So you will agree with me that this is actually a very serious problem that the world has to look at in terms of this donor disparity, and of course, the inequality that happens in terms of priority of different diseases. So therefore, it's important that in hospitals should try as much as possible to administer antivenom as early as less than 1 hour after arrival, and also strengthen stock management and decentralized supply so that patients will be able to have access to these antivenoms. Now, it's also important at the policy and financial level that antivenom should be made free or subsidized, like other elements that affect the same people of low socioeconomic class. It's also important to also integrate antivenom into essential medicine and insurance schemes. It's important that most recently we've noticed that we commend the federal government and state government in such a way that recently they've included it as part of an emergency medicine, whereby patient can be able to receive such care within 48 hours. When that is implemented in all parts of the world, whereby patients of snakebite can receive free interventions within first 48 hours, our patient will get well, and of course will have lower mortality and higher survival rate without poor complications. And of course, at the level of community and systems, it's important that we continue to educate our communities on early hospital presentation and also safe first aid as far as snake bites are concerned. It's also important to improve referral and transport systems because this forms the important basis for transportation of patients from hard to get areas to also to areas whereby we'll be able to have a lot of interventions. Also, it's also important to engage in more prospective multi-center studies and a lot of cost-effective analysis and of snake bite, and of course lifelong disabilities need to be addressed, which we're discussing at the on center. We want to look at the economic impact of this snake bite on the populations. This is what we are also trying to look at from our on center. Let's proceed. Now, from this study, where we studied 723 patients, we noticed that delay and cost leads to death and disability. Therefore, the child, and most importantly, their relations, their caregivers, are faced with a cruel choice to either pay early or perish. Therefore, government and donors must fund free or even subsidize anti-snake venom at this point in time to be able to reduce mortality. We must translate from pre-qualification to subsidizing or even making it free for our patients so that they will be able to get well. And it's also important to strengthen referral systems and supply systems. And it's also important to align snakebite with other donor-backed diseases. Now, every child is worth saving without asking for cash first. Thank you very much for this for listening to me. And actually, these are the references that we're able to go through. Thank you very much.
Thank you very much, Dr. Amani, for that incredible presentation. I ask folks if they have questions, please hold off until the end. I'm sure you have a whole bunch after hearing this. I will pass it on now over to Mr. Kingford Chimfwembe, who is a principal investigator and snakebite expert based at Lusaka Apex Medical University in Lusaka, Zambia. I'll just double check, Kingford, if you'd like me to share your slides or if you would like to share your slides.
Please help me to share my slides, Ashna. Thank you.
Sure. Sounds good. Let me just open them up on my end. There we go. Alrighty, take it away.
Okay, thank you very much and welcome to this presentation. So I'm presenting some of the work that we've done in conjunction with the Lusaka Apex Medical University, as well as the Liverpool School of Tropical Medicine. And compared to Dr. Hamani, that has done so much work in Snakebite in Nigeria, which I commend very well. When it comes to Zambia, I think there are still some gaps, but I'm glad that we are able now to fill in those gaps and see how best we can contribute to this very important public health problem. The next slide, please. Okay, that is just to recommend the people that contributed to this slide. Okay, the first one, the introduction. Next slide, please, Asna. Okay, so like I've said, when it comes to Zambia, there are very few studies that have been done on snake bites. And we still have challenges in as far as where data is concerned. So the only data sets that we have is data that we normally collect, in other ways, which is collected by Ministry of Health from the District Health Management Information System. But you and I will agree that normally DHIMS data is not very reliable. There are some cases where there is actually over-reporting, and in other instances, there are cases of underreporting. And even the few studies that have been done in Zambia, I think about 2 or 3, their focus basically were on healthcare training and also venom supply chains. When it comes to incidence as well as prevalence of snakebite cases, okay, so in this particular study, what we did was that it was a retrospective hospital-based study where we looked at some patient records between this. Next slide, please. The methods. So like I've said, it was a retrospective study. So we selected about. Are you able to get me?
Yes, sorry, all good.
Thank you. So we selected about 3 provinces, and the basis of the selection, of course, was based on the District Health Management Information System dataset. So we were as health facilities that had the highest number of cases that were reported. And in those facilities, we reviewed the files, and from the facilities that we looked at, only able to come up with 4 files which made our interview with the health workers, because all right. So we collected data from about 4 districts and health facilities. So like I said, we collected data from 2023 and 2024 on those facilities that are listed there. So what was actually important to note is that while we had a lot of cases listed in the district health management information systems, when we went to the facilities, in most cases, we were able to find half and less than half of the cases. So which means actually data integrity when it comes to what is reported in the health management information system is indeed a challenge. Next slide, please. Okay, so now we present here the characteristics of the patients. So for our Zambian study, the median age of our participants was actually 21 years. We had some participants as young as 12 that were in the data set. And when it comes to the time of the bite, so the time of the bite actually corresponds to what has been obtained elsewhere. Most of the bites occurred between 6 p.m. and midnight. And the site of the bite was the lower limb, which is, I was glad when Dr. Amani presented, because this is a bit different. Maybe it is because of the different populations in which these studies were done. But most of the bites occurred in the lower limb, and this accounted for about 78% of the cases. The next slide, please. Okay, so also try to look at the health-seeking behavior, because when it comes to snake bites, the time taken for the victim to reach the health facility is very important. So in our case, most of the participants reached the facility, or in other words, they took about 3 hours to reach the facility. And in the files that we looked at, most of them record the time when the participants reached the facility and the time they were beaten. So this information was lacking. And I think as we move forward, it is very important that we come up with the tool that should be able to at least record the time a person was beaten up to the time they reached the facility. Pre-hospital treatment was very common, like what has been recorded elsewhere. Incisions, traditional medicine, and the use of tourniquets were actually reported. So this is also one area that needs a lot of public health intervention. The next slide, please. So in terms of the symptoms, we recorded symptoms twice. The first, we recorded symptoms, the patient just arrived at the facility, and then we also recorded at any other time. So the major symptoms, just like what has been observed in some other studies, were pain as well as soreness on the part where the biting took place, and also swelling. Then the other symptoms are actually distributed. The next slide, please. So when we interviewed, or when we looked at the data for the symptoms that were recorded at other times, swelling continued, as well as other symptoms like numbness, other symptoms like sweating, shock, as well as collapsing in some cases. So these were the symptoms that I can say were in the more advanced cases of the envenoming. Next slide, please. All right. What was also important was basically just to look at how the snake patients were treated. So from our sample size, antivenom administration was very low. Only about 4.5% received the antivenom. So majority of the victims were not actually given antivenom. And from the Zambian case, the most widely used antivenom is actually the polyvalent one. Next slide, please. So lastly, we also looked at just the training capacity of the healthcare workers, so that we can understand how well or how confident they are in the management of these cases. And majority of them were not trained in the management of snake bites, because training was only recorded in about 38% of them. Next slide, please. And then also related to management of snakebite envenoming is whether our health workers were actually using any treatment protocols or not. Unfortunately, use of treatment protocol in the management of snakebites in the country was very low. And in Zambia, we recently developed some guidelines at the beginning of this year in the management of snakebites. But unfortunately, up to June or July, very few health workers that actually seen and use these guidelines, which actually shows a serious gap in the management of snake bites. Next slide, please. So what were the major findings? So the major finding was that most of the victims were actually very young, about 21 years in terms of age. And of course, that most of the bites, like I've said, occurred in the lower limb. This is what has been obtained in other studies. Next slide, please. So in terms of presentation at the hospital, 3 hours was the median time. So as we know, the time a person presents to the hospital is very, very important, because in some snake bite cases, if they're not presented early, the outcomes could be very fatal. So most of the factors that are responsible for this normally could be because of reliance on traditional medicine, but also mostly in these rural setups, most of the victims live very far from the facilities. So like I've said, antivenom use was very, very low. Most of the facilities actually did not even stock antivenom, and maybe for the past 2 or 3 years, there was no antivenom that was actually stocked at such facilities. However, I think because of the low sample of the victims that received antivenom, very few or very minor, if any, side effects were recorded. Next slide, please. Okay, so when it comes to healthcare training, like we've said, most of our healthcares are not very confident in the management of snake bites, and also most of them are not using any treatment protocols. But with the introduction of the new guidelines, we hope that this challenge could soon be addressed. Next slide, please. So moving forward, we hope that there could be more of community strengthening programs that will look at first aid and also just the living experiences of the snakebite victims. In fact, from the Zambian side now, this data has given us an idea so that we can now conduct more of community-based surveys so that the real burden of the disease can actually be known. And also the next aspect is the aspect of the healthcare training, because we see that as a gap. And as Lusaka Apex Medical University, in our curriculum development, we are planning of including the aspect of training health workers, so that most of the health workers that we produce, being a medical university, this gap would actually be addressed, and which can actually impact so much on the Zambian health system. There is need to enhance antivenom availability, though this is more of a government project, but I think based on the recommendation of these findings, we should be able to inform policy that the distribution of antivenom in the country is that there's a lot that needs actually to be done. And then last but not the least, we are of the view that with the data that is collected in the district health management information system, probably we can include some variables on snake bites, and then we see how rich data we can collect thereafter. The next slide, please. So as future studies in Zambia, we want to now expand this research to more communities or more hospitals, and also include aspect of outcomes, because in the current study, we did not include the outcomes of the snake bites, but we are proposing that in future, we can include such studies. And of course, community-based studies, our focus will be on the management of snake bites at community level, and also what role the traditional healers actually plays in this. And then last but not the least, on what are some of the challenges probably that may be related to the distribution of antivenom. I'm glad to report that in our small research units, there is one group that is looking at this, and I think at the right time, we'll be able to report what the findings will be. Next slide, please. Okay, so this is just to give the acknowledgements to the Liverpool School of Tropical Medicine, Lusaka Apex Medical University, the Ministry of Health, as well as the National Health Research Authority. Of course, not forgetting University of Oxford, as well as the Global Health Network. Thank you very much.
Thank you so much for a very interesting presentation.
Thank you.
Yeah, thank you. This is all it's very, very interesting, and I love seeing the parallels between the recommendations across different presentations. So thanks so much for taking the time to present. For anyone who joined, yeah, thank you. Anyone who joined recently, I will ask just to hold off any questions until the end, just so we can get through all of the presentations. So with that, I will pass over now to Dr. Eric Nyarko, who is based at the Department of Statistics at the University of Ghana. Although Dr. Nyarko's work kind of spans all sorts of disciplines, he's also a snakebite enthusiast among them. So welcome, Dr. Nyarko. Just checking if you would like me to share your slides or if you would like to share them.
Yeah, please kindly share. Thank you.
Sure, let me open them up. There we go. All right, the floor is all yours.
Yes, greetings everyone. I'm Eric Nyarko. I'm a senior lecturer from the Department of Statistics. And also I lead a vibrant research team in Ghana. As part of International Snakebite Day, I would like to present on advancing community-based snakebite envenoming research in Ghana. Next. So in the next slide, I'd like to show you. So I went online. I saw some common snakes found in Ghana, and I've also provided, a source for people who are interested to know more about common snakes found in Ghana. So from the next slide, you see that, yes, so as part of our community-based study or visit, we saw that, or we found out that community members in a particular region in Ghana use Siobin, to repel snake, repel snakes. We also saw this snake killed as part of our community visit. Yeah, so you can see that like the snakes are all over. We also found out that community members use this black concoction to treat snake bites. At the community level, and on top right, you can also see a scar from a snake bite victim. We also saw this snake antivenom in the health system, though this snake antivenom is not part of the WHO list of recognized antivenom, but we found it in the health system. So in the next slide, we will begin with some background. So global annual report of snake bites exceeds 5 million per the WHO. And there's an estimated 435,000 to 580,000 snake bites that really occur in Africa, and that need treatment. Snake bite represents a serious public health problem in Ghana. However, complete epidemiological data on snakebite is inadequate in Ghana. And most of the cases are not reported. And the reasons include lack of confidence in the medical systems to effectively treat snakebite cases. Also, like the reason for underreporting of snakebite cases is due to poorly resourced health facilities that really struggle to manage snakebite cases. There's also limited competencies among healthcare workers. And this has been pointed out by my colleague here from Zambia. Next point, also, there are myths and traditional beliefs systems in certain communities, and this may worsen challenges faced in trying to address this public health emergency in Ghana. So we also have interest in snakebite research, and there's a gap. We have identified a gap. So as we all know, the World Health, please, next point. So as we all know, WHO has launched a global strategy to halve the burden of snake bites by 2030. And since the launch of this strategy, there has been growing interest from decision makers for high quality evidence-based research to inform suitable policies and interventions, including the design and implementation of locally relevant plans. However, we have found that there's limited high-level research evidence in Ghana, and this leads to scanty scientific evidence-based knowledge on snake bites in our settings. So we believe that improving information on snake bites through advanced community-based research or data-driven evidence is crucial to improve snakebite treatment and management in Ghana. So what is the solution now? If we believe that in order to achieve the WHO's target by trying to halve the burden of snakebite envenoming by 2030, we need innovative research. And in doing so, we have to expand the traditional methods used in health research, modify existing methodologies, and integrate new tools such as machine learning or AI to gather better snakebite information in Ghana. In doing so, we can create a stronger foundation for developing strategies that meet local needs and also help to and also meet the WHO's goal of reducing the burden of snakebite envenoming by 2030. So our research so far, there's a gap that we have identified, and this gap is limited advanced research evidence in Ghana. So our work in this area of snakebite seek to explore advanced statistical methods, where here we employ traditional modeling technique. Another focus of our data-driven research is where we consider AI or machine learning related models. So in the next slide, we would like to show some published work from Ghana. And here, our model, so here we try to model the challenges that is linked to, the availability, accessibility, and use of antivenoms for treating snakebite and venom. And if, the figure on the right-hand side show that the major barrier in treating snakebite is high cost of what? Antivenoms. So you see, our model has pointed out the high cost of antivenom as a major barrier in treating snakebite in Ghana. And this has also been pointed out by our colleague from Nigeria. Okay, and he pointed out, yes, he pointed a high cost of antivenom as an issue. So next slide. So our next work also tried to model healthcare workers' prioritization of snake antivenoms that you can find in Africa. Okay, so we want to look at healthcare workers, their prioritization, and our model has pointed out that healthcare workers have prioritized Innocep Pan-Africa antivenom. Okay, yeah, so that's the most prioritized antivenom, followed by Premium A antivenom and Equitab Plus. So these are some of the antivenoms that have been prioritized by healthcare workers based on our model. So in the next slide, we show our next work. Our next work that is based on machine learning techniques. So this work from Ghana, where we provide a data-driven insight, try to consider the previous data. And in this work, we trained 6 machine learning models. As you can see on the top right, we trained 6 machine learning models, and all these 6 machine learning models, if you look at the higher peaks, the first higher peak in the figure still pointed high cost of antivenom as a major barrier for effective snakebite treatment in Ghana. In the next slide, our next slide also consider machine learning technique. And here, in this work, we try to model healthcare workers' priorities of the WHO strategic objectives. So we know that the World Health, WHO has 4 strategic objectives. Yes, so the WHO has set 4 strategic objectives to help in controlling and preventing snakebite and venom. So this work, we trained 5 machine learning models, and we decide to sort the views from healthcare workers as which of these WHO strategic objectives should be prioritized in Ghana. So all our 5 machine learning models pointed out that in order to meet the WHO's 4 strategic objectives, or in order to contribute to the WHO's 4 strategic objectives or their targets, first, in Ghana, local action plan has to consider, we have to ensure safe and effective treatment, followed by strengthening health systems. And the third priority should be, to empower community members. And the fourth is what? Is to increase participation and coordination. So these are the priorities that our work suggests that in Ghana we have to focus on in order to contribute to the WHO's target of reducing snakebite burden by 2030. So in the next slide, we provide a conclusion. So as conclusion, statistical methods and data analysis using AI or machine learning represent an innovative research approach for snakebite envenoming research in Ghana. Our work so far have pointed out that the primary barrier to antivenom treatment in Ghana is its high cost. Its high cost, poor access to antivenom in remote areas, stock out of quality antivenoms, and also unavailability of antivenoms that are specific to local snakebite species. Our work has also pointed out that, so regarding antivenoms, our work has pointed out that Ghanaian healthcare workers have prioritized Innocep Pan-Africa polyvalent antivenom and also Equita Plus. It is interesting to know that polyvalent antivenom in general are prioritized over monovalent ones. And this is also, clear from our colleague from Zambia, where he pointed out that there were 71.4% cases where polyvalent antivenoms were used in Zambia. Also, yeah. So the next point. Also, in order to meet the WHO's strategic objectives in reducing the burden of snakebite and venoming, healthcare workers believe that the healthcare workers believe that we have to prioritize ensuring safe and effective treatment, followed by strengthening health care systems, empowering and engaging communities, and increasing partnerships in order to meet the WHO strategic objectives for reducing snakebite envenoming by 2030. Now, to improve the situation of snakebite treatment and quality of patient care in Ghana, there should be an integrated strategy, which include community education, healthcare worker training, and this has been pointed out by my colleague or my colleagues. Also, we have to also develop local antivenoms. We have to encourage the development of local antivenoms. So thank you. Thank you for your, thank you. And I would like to express my sincere gratitude to all collaborators for their valuable contribution to this work. Thank you very much. Over.
Thank you so much for your presentation. It's very interesting to see all the advanced statistical methods and models that you've used. I think this is something that's quite new to this field. So I'm sure people have lots of exciting questions as well. Again, for those who joined recently, please hold off any questions until the end. I will now pass on to the last presentation from Dr. Nathanael Sirili. Just checking that he is here. Yep. He is here. Awesome. So Dr. Sirili is a lecturer and researcher at the Muhimbili University of Health and Allied Sciences in Tanzania, and actually one of the recent awardees of the African Snakebite Alliance postdoctoral grant. So big congratulations to you for that. I'll just check if you would like me to share your slides or if you would like to share them on your end. Oh, I don't think we are able to hear you. I can see you are talking, but I'm not able to hear. Perhaps it's the headphones or something I'm not able to hear quite yet. Just give a moment until audio is sorted out.
Hello, I'm contacting him,
hello.
so I hope he will join soon.
That sounds perfect. Thank you so much. That sounds good. We can give him a moment to join. In the meantime, I will just share this presentation. Oh, hello, welcome back.
He is joining. Hello,
Ashna. Yes. Hello. Hello.
He is joining.
Yes, I see he has joined, but I think the audio issues might still be persisting. We aren't yet able to hear him. Oh, I can see him. In the meantime, I see our colleague Jackie has a comment in the chat to say, excellent complementary presentations that contribute to understanding the scope of the regional problem of snakebite envenoming and planning strategic actions to address it. Oh, I see he is back. Dr. Sirili, are you able to hear us? I think we are still unable to hear him. Perhaps if you're able to join. Oh, I see one more. Oh, hello, welcome.
I have joined using another device.
Oh, fantastic. We can hear you now.
Thank you. Yeah.
Awesome. The floor
I
is
don't
all
know what
yours. Thank
happened.
you.
Thank you.
No, all good.
Yeah, so greetings everyone. As introduced, I'm Nathanael Sirili from Muhimbili University. With my colleagues, I wish to recognize Mr. Manasseh Kilonzi and Margaret who have been able to join. And the rest of the team was displayed in the screen. Who unfortunately, for some reasons, have not been able to be with us. Next. Yeah, so as you have heard from colleagues, snakebite And it causes many deaths and permanent disabilities. Death, disabilities including amputations, tissue necrosis, renal failure, and we have seen that the burden is estimated at around 4.5 to 5.4 million annually and up to 138,000 deaths globally. Disease burden is highest among agricultural workers, pastoralists, children, as we have seen from colleagues from Nigeria, and people living in remote areas. And reporting actually and poor access exacerbate the impact of the snakebite envenoming. Next. So our problem from the Tanzania side is that the snakebite envenoming burden is underestimated due to facility-only data. Currently, the country does not have a comprehensive database for snakebite in the country. And for that matter, estimations are often underreported because many victims never present to biomedical health facilities, and also lack of the registry or database make the quality of the data poor. And as for colleagues reported from Nigeria, I think Zambia, and Ghana, many parts of Africa, the context is the same, that many of the snakebite victims approach first the traditional healers or home remedies before they come to health facilities. And a good number do not make it to the health facilities. So the burden in Tanzania, I can say, is not well quantified. Next. So as have been introduced, we are just a new group that has been awarded this postdoctoral grant. And our goal is to pilot a community integrated snakebite surveillance and response model, which now will improve data capture, access to care, and referral pathways. So that next year, inshallah, or the other year, when we come to this meeting, we also report about the epidemiology of the snakebite and the access to care and how we are saving lives and reducing disabilities and deformities because of the snakebite envenoming. Next. So this is a snapshot of our model. Currently, we start from the snakebite victim. There are two options that are readily available to this person. Either to go to a traditional healer, where majority go, or to go to the health facility, where few go, or they go after going through the traditional healer. But currently, as I'm speaking, these two systems, the traditional healer and the community health workers, do not communicate when it comes to snakebite envenoming. Pilot projects has been done in tuberculosis, where a patient with the tuberculosis also approach the traditional healer, linked to the health facility. But for snakebite and many other conditions, the linkage is not there. But in Tanzania, it's among the very first country globally where the primary healthcare system actually got its lives through the community health workers. Those days known as village health workers. So we still have this system of community health workers, and now they have been more advanced in the sense that we, instead of having just community level volunteers, we have community volunteers and we have community health workers who are trained to be able to identify some symptoms and be able to link these patients to care after some form of first aid. So we wanted to develop a model that will integrate the community health worker, the traditional healer, using a mobile application from the spots of the snake bite and link them to the facility. Tanzania, as many other poor countries or low resource countries, we don't have good infrastructures, especially to effect the referral system in rural areas. So for that matter, even the transportation of these victims is a major challenge. So in our model, we wanted to link our existing system, which is based in the community, the so-called M-Mama, which is used for helping pregnant women access care by timely transportation. We want to link this system now to Snakebite using a mobile app. Once there is a victim, using our traditional, using the community health record traditional healer, will press a button or an app to inform the facility that there is a snakebite victim. And in the same time, it will send a signal to these community owners of the transport facilities or vehicles to come and pick this patient and link to the facility. At the same time, that mobile app will send information to the district dashboard where we can have the data in the hotspot where the snakebite envenoming occur mostly. And we'll be able to map that there is access to antivenom in the facilities or plan appropriately which facilities need more antivenom compared to the other to ensure access to care. Next. So our research question, based on that, a simple model, as simple as I have spoken, but very complicated on how to implement it, is how effective is the community integrated surveillance system and response model in improving snakebite envenoming data accuracy? How is it effective in hotspot identification? And how is it effective in improving access to care? Next. So our hypothesis is that if this model works better, it will yield accurate snakebite envenoming data. So we'll be able to establish the magnitude and the epidemiology of the snakebite envenoming in our country. Of course, we are piloting it in just one district, and then we hope it will be a scalable one. So it will better identify hotspot using community data and the geospatial information system, and it will improve referrals and reduce delays to care. Next. So where are we going to implement this? We are going to implement this project in Mkinga district, which is a northern east district in Tanga region, Tanzania, which is a predominantly agricultural or pastoralist population. As in my previous slide, you may have seen that the most affected population are agricultural pastoralists. So this is a fit for that. But again, we have done some previous studies in Mkinga, not specifically on snakebite, but in general in animal-related injuries. And we realized that snakebite is a significant under-recognized animal-related injury in this district. But again, there is limited antivenom stock in the existing health facilities, and there is long distance travel to health facilities for snakebite victims, as this is a much more mountainous district and a rural, typically rural district. But again, there is delayed to care due to the use of home remedies, attending traditional healers first before going to the facility. And this is among the district that has predominantly cultural beliefs, especially in management of snake bites. So we hope it will bring an impact when we implement this model. But again, as there is no community surveillance system, the poor surveillance we use masks the actual burden. So it is not known. Next. So this is Tanzania. For people who have not been to Tanzania, it's the largest country in East Africa. Its size is larger than Kenya and Uganda combined. It has around 63 million people. It has 30 geographical regions, geopolitical regions. And see the point by the arrow. Next. And Tanga has 10 councils. In other words, we have 10 district councils in Tanga, and we're only going to Mkinga district, which has 21 wards. So it's also large. Next. So we expect that we will implement our project in 4 phases. Phase 1, which we are now in preparation, is the situation analysis to be able to establish which ones out of the 21 ones has the highest burden, so that we can test our project in one of those high burden with the one implementation site and the another as a quasi-experimental site for controlling what is happening in the intervention site. The phase 2 will develop the model. It will be a co-creation. We'll work with the community, the local people in the area. We'll work with the IT expert to develop the online app, and then we'll go to the implementation, which is a quasi-experiment, as I have said, with the one word put in the intervention, another setting as control, similar words, to ensure that we minimize the chances of bias. But again, we'll end up with an end-line evaluation, which is our last phase, which will be able to show the lessons you have learned for scalability or for areas which need more strength before it is being scaled out or phased to other places. Next. So this is, in summary, how it will be implemented. We implement it in 4 phases. As I've said, phase 1, which is expected to go through December. By December, we expect to have finished the situation analysis and we have known the added and throughout June 2027. Next. So we have some key innovations. As you may have seen, we are using mobile app to link community health workers, traditional healers, and healthcare providers. We use the M-Mama. Mama is a Swahili term for mother. So M-Mama is M for mother, emergency transport system. And we are also trying to get real-time data collection and antivenom logistics to ensure that we strengthen the community health system, and by so doing, strengthen the primary healthcare, which is where 70% of the population in Tanzania go first for the care. Next. So we really combine mixed methods, quantitative survey, qualitative, where we really go to 22 words is stratified. One is urban, so we remain with 21, and we will carry thematic and geostatistical analysis. Next. So we expect at the end, we'll have improved SB surveillance and data accuracy. We'll have better hotspot mapping and targeting, and we'll improve community health system linkage to the formal health system, and thus improving access to care for snakebite victims. Next. So we expect that the evidence will inform the Tanzania snakebite envenoming guidelines, which we don't have a specific guideline for managing the snakebite envenoming in the country. It's just part of the major treatment plan. But again, this will support the WHO 2030 goal to have snakebite envenoming death and to establish a scalable community-based surveillance model. Next. So again, as I have said, this is a community-based model. So we will involve the community health workers, traditional healers, will be trained for surveillance, both the community health workers and traditional healers. So they will be provided with electronic gadgets, the tablets, to be able to collect the data, to use them, and to link the victim to the facilities. But again, we'll include the victims' voices to guide the model design using a co-creation. And as I have mentioned several times, now you may start to be familiar that we will link them with the transport system, the M-Mama, to ensure timely care. Next. So this is the team, and we bring in different expertise. Myself, an associate professor in health system and policy, who is leading this team. But the co-investigators come from diverse professions, pharmacy, toxicology, and environmental health. And this is a collaboration between two partners, Muhimbili University, abbreviated as MUHAS in Tanzania, and the University of Lubumbashi from Democratic Republic of the Congo. So thank you very much. And I wish to acknowledge the Snakebite Alliance, the London School, and all the partners for supporting us to start this work, which we envision that it will grow to something big and help to address the burden of snakebite envenoming to save death and morbidity, not only in Tanzania, but to different places with a similar context. Thank you very much.
Thank you so much for that presentation. I can speak for everyone, I think, when we say we are all very invested in this now and very keen to hear updates as the project goes along. So we are all cheering you on. But thank you for sharing your plans with us. I see that we have about 12 minutes left in the meeting. Perhaps I will open the floor for anyone who has questions for our speakers. And of course, speakers, if you also have questions for each other, feel free to ask. The chat as well. Our colleague Nuhu is saying, leveraging on the existing M-Mama program to connect the traditional healers, village heads, and healthcare providers is very commendable. Perhaps I can start by asking a question as well, and I guess this is a question really for all speakers, because I think this is something you brought up quite often in most presentations, and it was about antivenom and access to antivenom. Oh, actually, I see there's a hand. I will save my question, and we'll let, is it Manasi? Go ahead.
Hello, good evening, everyone. So,
Hello.
can you hear me?
Yes, we can hear you.
Yes, my question is not directly to anyone, but if anyone can respond with it among us, it will be good. From presenter from Cameroon, the recommendation was to think how can we make our own antivenom, and I think this is the area that we need to see how do we address it, because we are having a lot of snakes in our settings. I'm coming from Tanzania, co-investigators alongside Professor Nathanael Sirili. But now my worry is we have a lot of snakes in our settings, but it's like we are using only one antivenom. We are using one type of antivenom to treat all victims. So can someone comment on that? Thank you.
Thank you for your question. Would any of our speakers like to comment on that?
So thank you for your question. So of course, let me say in my presentation, let me say that this is, a major issue in our part in Africa, where there are instances where you can find a antivenom in a health system, and this antivenom is not meant for local snake species. Okay, so of course, it is important that local government also invest in the development of local antivenoms. And this has also been pointed out in my presentation or some of my works so far. Thank you. Yes.
Thank you. Dr. Amani or Mr. Chimfwembe, did you have anything you wanted to add? I saw you had unmuted earlier.
Oh, yes. Can you get me, Hasna?
Yes, I can hear you.
Yeah. So I think when it comes to antivenom, it's like Dr. Amani has said, things Africa don't have the capacity, and hence we depend on antivenom that has been produced elsewhere. But currently, there's a team from Liverpool School of Tropical Medicine the clinical trial, the snakes trial, where I think about 7 antivenoms will actually be tested in Africa. And I believe I'm meant to understand that most of those actually have been made from snakes from Africa. And I hope that can actually also bring in a lot of relief, provided we can have a favorable result from such antivenoms. So when it comes to antivenoms, the polyvalent normally is preferred because it tends to cut across the different types of envenoms. I think that is the reason. So maybe I thought that I could just contribute like that. Thank you.
Thank you. And Dr. Amani, did you want to add anything?
Yes, thank you for your question. I think it's also looking at it from the perspective of the patient and also from the perspective of the producers. No, from the producer side, venom is actually a very big venture that requires a lot of resources and a lot of expertise and takes a long time for these things to be able to take place. And of course, that is why it's important for governments and also to donor organizations to come into play for such kind of venoms to be produced. The more the merrier, because the more different antivenoms, the more the merrier, the more one can be able to choose which one is more effective than the other and can use it. But when you have just an antivenom, you tend to have just completely dependent on it and you have more problems as well. So from the patient side also, it's important to also know that it's not the availability of the antivenom too, also affordability is also important. So I think that is why addressing snakebite requires not just providing the antivenom, building capacity of the patient to be able to acquire it or delivering it free or subsidized is also very, very important as well. So I think looking at it from this perspective, polyvinyl antivenoms have been found to be used most commonly because of the fact that they cover a range of snakebite species. But we also have monovalent antivenom that cover a particular species of antivenoms. But this all boils down to capacity to produce and ability to afford. Thank you.
Thank you so much. I think I will pass it on to Chloe to ask a question. Go for it.
Hello, everyone. First of all, thank you so much for these incredible presentations and for all of your work on this neglected tropical disease. Yeah, a lot of incredible innovation being done. So congratulations on that. I think one thing that I found really interesting about this conversation on antivenoms, first note, is I think ideally a lot of antivenoms would be made for local snakes, but I'm curious what all of you think about the rising costs that would likely happen, and also including the history of the South African antivenom who has been out of production because of the difficulties of maintaining such a costly production of antivenom. So I think that that's one interesting thing that I'd like to hear all of this discussion about. So thank you all for mentioning this topic. And then one other question that I found interesting in one of the presentations, I can't remember which one. I think you've mentioned that over-reporting happens. And in those cases, I'm curious, how does this occur? What's going on? So thank you all very much.
Thank you, Chloe. Do any of the speakers want to start by answering Chloe's question?
I can go first if you allow me.
Yeah, go for it.
Thank you. Yeah, I will start with a reflection on the issue of developing antivenom in each country. I find it to be very expensive, and I think looking at the context of my country, Tanzania specifically, where we are not yet sure of the burden of the snake bite in the country, it is very hard to advocate for the antivenom development. Because if you go with the cost benefit analysis, you may realize that without the true burden, you may end up overproducing and having a high cost than importing from elsewhere. Perhaps I would advocate for a regional, maybe center for developing antivenom, assuming that it will be able to take care of the multi-species of the snake around in many regions of Africa. Not only regional, I may say maybe global centers, several centers to be able to produce, because otherwise having center in each country may be very expensive compared to the actual need, which is not yet known. The second thing I would wish to reflect is the question asked in the chat by Jacqueline Adria on whether there are specific examples on strategies to mitigate the harmful practices of pre-treatment in the community. Yeah, this is a very pertinent question. But before terming them harmful, you need first to establish whether they work or not. Because some of these practices do work. And in some places, you find that they use the very same snake. They kill that snake, they burn it, they use those products from that snake to treat snakebite, and the patient get healed. I have found this in some of the Western regions in Tanzania. So perhaps we need to invest more in understanding these sociocultural practices to be able to single out those that are harmful, and then it is through healthy promotion education where we can address them. I wish to stop there to give opportunity for other colleagues. Thank you.
Thank you so much. Do other colleagues wish to answer as well? Dr. Nyarko, Amani, Kingford as well?
Hello?
Oh, Smaila, yes, we hear you. I think we'll move, if other speakers don't have anything to add, we can move to your question.
Okay. Hello, Asana.
Hello.
Can I speak?
Yes, one moment. I'll just check if others have something to add to any of the previous questions first.
Okay.
Yes, from my own end, the issue of over-reported actually maybe is not part of my presentation. However, the issue of specific example of strategies to mitigate some of those practices, I think it's also important for us as Africa, maybe as areas whereby those snake bites occur, to look at local solutions as well. There are so many local solutions. There are things that patients consume. Of course, medically, we may look at it as harmful practices. And of course, we talk about it in literatures, in journals, in presentations, say delay in practice, taking of traditional concoction and all those things. I don't know whether there is need for, I don't know, but I feel there is need for us to look at those things. What are they actually doing? There are communities that have some trees or plants that when it is planted, snakes don't go there. And I do not have the privilege of seeing those kind of things, but I feel that when things like this, we hear these things, it's important as communities where those snake bites occur, try those things, subject them to scientific investigations, bring out findings, and maybe that may serve as a local solution that can reduce some of those things. Those local solutions that we look at them as harmful practice can be local solutions that are embedded in our communities to reduce the menace of these snake bites. Thank you very much.
Thank you. And I saw Kingford, you'd also unmuted. Did you want to comment on the over-reporting?
Yes, Asna. Thank you very much. So my experience during the data collection, also as it regards to over-reporting, was that there was usually a discrepancy between the records that were indicated as coming from the facility and then compared to the actual patient files that were actually operating at the facility. What I observed basically was that there were some cases that were actually maybe treated at the outpatient. And then for such cases, sometimes you couldn't even find the names, you couldn't find the exact details of the patient, the outcome, and what happened. And I think in the reporting, such were reported as the cases, But in going further and to find out what kind of a case it was, what happened to the victim and all that, that wasn't the case. Then the other challenge also was that in terms of record keeping for most of the facilities, I think that was a challenge, because there was situations whereby quite all right, we have been given the patient number for a particular file, but when you go check for the record for that particular file, you may not actually find it. So I think it's more of a complex situation that needs all concerted efforts in trying to address it. I think that would be my contribution. Thank you.
Thank you. I will now pass it over to Smaila to ask a question.
Okay, thank you, Asana. Thank you for everybody who present us the kind presentation here. But I have one question for the person who presented the community-based surveillance in Tanzania. I want to know if they make any kind of motivation for community workers to improve their notification. I don't know if I can ask now, please. Can I ask my question in French, because I'm not fluent
Sure.
in speak. Okay, thank you very much. Merci beaucoup. Excusez-moi, bon, mon anglais n'est pas. J'arrive à vous écouter, mais le parler est un peu difficile. Je suis en train de le faire de temps en temps en vous suivant. C'est par rapport à la présentation qui a été faite en Tanzanie pour l'amélioration de la surveillance à base communautaire. J'aimerais savoir si vous avez mis en place une sorte de motivation pour que les notifications se fassent correctement au niveau des travailleurs à base communautaire, les travailleurs de la santé communautaire, et aussi des tradithérapeutes, parce que nous savons que ce sont des gens, surtout les tradithérapeutes, ce sont des gens qui refusent vraiment de faire la notification, parce qu'ils se disent que quand ils font la notification, on va leur prendre les patients. Bon, en dehors de cette question, j'ai parce que je voulais aussi apporter mon point de vue par rapport à la fabrication des antivenins au niveau national. Je pense que déjà, Dr Nathan a apporté vraiment mon point de vue. Je pense que ce n'est pas économiquement viable pour que chaque nation, c'est vrai que nous avons des profils des serpents différents selon les pays, mais on a un profil régional connu. Donc, ce qui serait vraiment économiquement viable pour nous, les pays africains, avec tout ce que nous avons en dehors des morsures de serpents, je pense que c'est une régionalisation qui serait la meilleure des choses. Par exemple, l'Afrique centrale, on connaît le profil, avoir leur base de fabrication, l'Afrique de l'Est, pourquoi pas même au niveau africain, l'Union africaine, parce que quand j'ai lu la littérature, je sais qu'au niveau de l'Union africaine, il y a des initiatives pour pouvoir faire une fabrication pour que l'accessibilité soit abordable pour toutes les nations. Donc, je pense que c'est nous qui sommes des chercheurs, c'est des initiatives qu'on pouvait vraiment supporter pour qu'on fasse une certaine régionalisation. Sinon, si nous voulons faire les choses dans chaque pays, ça ne serait pas supportable et non viable. Merci beaucoup.
Merci, Smaila. If I could recap that it's a question for Dr. Sirili about how the community health workers and traditional healers, whether there's any incentive or engagement strategy for them with this notification system. But then Smaila was also agreeing with one of the previous points that it would not be neither economical nor sustainable or viable to have a sort of country-specific anti-venom, rather having something regional makes more sense based on the regional profile of snakes there. So thank you for your question. I hope my French is a little bit shaky, but I hope I captured what you mentioned. Perhaps I will pass it over to Dr. Sirili to answer.
Thank you very much. And yeah, I enjoyed listening French. My French is very little, but I could get some few things. Thank you for amplifying it. Yeah, so We will motivate them for sure. One is the capacity building that they will receive. They will be trained to be linked with the formal healthcare system. For community health workers, that is already happening. For the traditional healers, as I said, it is happening in tuberculosis. Is also project-based that is on a pilot. But the major fear for them is when you try to link them to health facilities, the fear will be on the economic benefit that we are getting by these people in there. But in this intervention, they will receive electronic gadgets, tablets, which they will keep even after the project, because we assume that they will continue to work. But they will also receive some token for their bandwidth to be able to push the data. But the continuous engagement and refresher training will also uplift their recognition as valuable people in the community. Although people go there to these traditional healers, not everyone goes there in the daylight. Some people go at night, especially when it's linked to religion. You cannot go there. For instance, I'm a Christian or a Muslim going to a traditional healer day broad light. So people go there, but they go there not openly. So by integrating them, also you uplift their value to the community that these are not witches. They are actually alternative healers. And they have been there for many years before the modern or the Western medicine came in. So we'll improve their value in the community, but they will also receive some financial tokens and they will receive the electronic gadgets. Thank you.
Thank you. And thank you for your question. I was just putting it into a translator as you were answering. So hopefully that answers your question, Smaila. I saw there was one more hand. I do recognize we're a bit over time now. So perhaps if there are any sort of remaining burning questions, I saw there were some in the chat, but I think speakers might have answered those kind of in their questions as we were going along. But perhaps we can sort of wrap up there then. I will once again thank our 4 speakers today. Your presentations have been incredibly engaging, and it's amazing to know all of the work that's going on in different parts of the world to tackle this neglected tropical disease. As always, folks are welcome to our monthly Snakebite Hub meetings, the next of which will be next Friday. And yeah, just feel free to get in touch with myself or any of the other speakers here. As I said, we're a tight-knit community, and everyone's always willing to talk and to collaborate, which is something we totally encourage here. So once again, thank you, speakers, and thank you to those who attended and asked questions as well. Hope you all have a lovely rest of your day. Take care. Bye-bye.